I just understand that they're not ready with the live case from St. Anne's Hospital, so we're going to continue with the program. I will introduce you and ask to invite Professor Hellstern to speak about cerebral venous thrombosis.
Okay. Well, thank you so much for the invitation. It's my pleasure to present a little bit about the endovascular management of cerebral venous thrombosis. So some general considerations, as you all know, sinus thrombosis is a rare cause of stroke. It's less than 1% of all strokes. However, the mortality is 4.4% and increases to over 50% if it is associated with severe symptoms, such as coma, ICH, or elderly people. Anticoagulation is the standard therapy of choice. However, up to 13% of the patients still have a bad prognosis despite that. So we can basically summarize the treatment strategies into two groups. One is the conservative group that mainly consists of the heparinization, and the second group is the endovascular thrombectomy. The conservative management, as I already said, the heparin is and will always probably be the gold standard for sinus thrombosis. However, it's very important to keep in mind that you need to avoid all procoagulant drugs in these patients. Supportive measurements such as elevation of the upper body is of course also necessary. And in some cases, when it's like a last resort, it can also help to think of an escalation of the medical treatment of these patients. So which patients do we primarily treat conservatively? These are, on the one side, patients with partial occlusions without a venous outflow obstruction. There was a patient that suffered a seizure and had the MRI, and you can see, here that there's some clot in the superior sagittal sinus. So we took him into the cath lab and did a diagnostic angiogram just to confirm that it was really no venous outflow obstruction, no congestion of the cerebral cortical veins, which was not present. So we decided to go with a conservative management in this case. We put him on heparin, and after 2 weeks, the MRI showed a complete recanalization. The other big group of patients that have to be treated conservative is, of course, the cortical veins, as we can't do anything mechanically in these veins. However, if you go for therapeutic heparinization, they usually have a very good prognosis, at least in our experience. And as you can see here, we have a complete recanalization as well. And the last group of patients is patients with acute and chronic sinus thrombosis. As you can see, when EVT fails. In our experience, we've done 3 cases that were acute and chronic, and all 3 cases EVT failed because the patients had so massive septations that it was basically nothing that we could aspirate or get out. In this patient, as you can see, basically everything was occluded, all the sinuses. So we still tried to go endovascular because of the extensive thrombosis that she had, but literally every catheterization was really hard. In the end, we did even PTA, which we usually avoid, to not press anything further into the orifices of the cortical veins. But still, the recanalization result in this case was not really sufficient. And in her case, we started out with heparinization, but she didn't improve overall. And so we discussed with the family what to do. Do we escalate? Do we go off-label, of course? And the family was aware that everything was off-label, but they wanted whatever we could do. And this is basically what we did for her. And I'm not saying you should do that now in every case. That's for sure an extreme medication regimen. What I'm trying to say is that in some patients, as a last resort, think not only of heparin, but also you might want to add platelets as well. And she actually made a complete recovery clinically and also from the MRI images. So in her case, it was worth the risk. So to summarize conservative management, that's our primary approach in partial occlusions without impairment of the venous outflow, isolate cortical vein or internal cerebral vein thrombosis, and as I said, acute and chronics. Then, however, on the other hand, there seems to be a subset of patient that empirically benefits from endovascular therapy. These are the young patients, the patients with a high thrombotic burden, and of course the ones that deteriorate despite the heparinization. And if you go for endovascular therapy, how do you do it? And again, that is what we preferred in our department. So what we preferred aspiration thrombectomy, and in detail, that is the realizes that I will show you in the next few slides. Sometimes in combination with mechanical clot fragmentation using either snare, stent retrievers, microwires. Angioplasty is something that we don't like, because, as I said, you have the risk of pushing the clot into the orifices of the cortical veins and making the situation actually worse than better. And also local fibrinolysis or stenting in the acute phase did not work really well in our experience. What's important is without heparin, you can do the best mechanical thrombectomy in a sinus thrombosis. It will be worth nothing because it will just simply reocclude. So the patients have to be on heparin during and after the procedure. So realizes, what do we mean with that? Realizes means it's an alternating flushing and aspiration with large volume aspiration catheters. So if you want to, it's a little bit like a mechanically cyclic aspiration variation, maybe. That is a case of a 16-year-old patient. She had headaches for more than a week. Then she got worse, deteriorated, presented with aphasia, apathy, and in the end she lost consciousness. The only known risk factors were oral contraceptives. And as you can see, of course, she has this bithalamic edema, an occlusion of the straight sinus and the internal cerebral veins. And the DSA is the initial run before the recanalization. Did it? Yeah. In lateral, so you will just see that the straight sinus and internal cerebral veins are occluded. And then we went with a 6-French Sophia, because that was the biggest aspiration catheter we had back at the time. Brought it up to the straight sinus over an echelon and a synchro microwire. And then the video should, okay, you will see only part of the video, but this is actually the reolysis. So this is the first injection, which you create smaller fragments of this huge clot that is in the straight sinus, followed immediately by aspiration manually. And ideally, you also advance the aspiration catheter back and forth to increase the effectivity. And this is actually then the final run. After a few times of repeating this maneuver, as you can see then in the lateral view better, the straight sinus is patent. It's slow, of course, because internal cerebral veins are still occluded, but the outflow is improved and it gives the heparin the time that it needs to work, actually. So, yeah. That's another case. That's also a young patient, actually a nurse from our ward. 7 days after COVID vaccinations, she had a seizure during work. She had a CT scan that looked rather okay. So you see the dense clot in the superior sagittal sinus. We had an MRI where you can also already see that she had mild SAH, and she has a really extensive clot burden in the superior sagittal sinus, transverse sinus, and the straight sinus. So in her case, we also took her to the cath lab and decided to go for recanalization immediately. Again, you can see here the high clot burden that she had. And this is should be again the video of the reolysis maneuver, the first injection, followed by the aspiration. Of course, you stay in the sinus, you spare the cortical veins, and in the lateral view, you can appreciate it better. Exactly. And then ideally you go a little bit back and forth with the aspiration catheter. And with this maneuver, we were able to recanalize the complete superior sagittal sinus within 31 minutes, which is actually a pretty fast given the extent of the clot burden that she had. And she also made a complete recovery. The last case I'm going to show is a similar case, superior sagittal sinus occlusion. He already had a small ICH. So we also took him straight to the cath lab. The initial run, again, will just show you the occlusion of the superior sagittal sinus. Again, you will see it in the lateral view better. And actually, in his case, it was for some reason not possible to bring the Sophia really to the distal part of the superior sagittal sinus. That's why we used in this case a big and rather aggressive stent retriever, at least for our liking, in the arterial side, aggressive, and used it in the vein to help fragment this clot in the distal part of the superior sagittal, followed then by rheolysis with the Sophia again, and probably this is also running. So again, this is what you've already seen now twice. First injection of diluted contrast agent so that you see what you actually do, and then the movement of the Sophia catheter. And again, you see the recanalization result. It's not a complete recanalization like you would expect on the arterial side, the TK3. You really don't need to do that. You want to improve the venous outflow. You want to give the heparin the time that it needs to act. So you just need to go as much as you need to improve the outflow and reduce the congestion. So finally, I would like to make a few comments about when should we treat these patients, or does it matter? Is there a correlation between the time to EVT from symptom onset and functional outcome? And that is something that we analyzed in our patient cohort together with the Hospital of Bern, and we had 45 patients that were treated endovascularly, 31 patients early, so within 24 hours of symptoms onset, and 14 patients late. Both groups did not vary between the baseline characteristics, so clot burden, sinuses involved, neurological deficits, coma. These were distributed equally between the two groups. And what we basically saw is that the patients that were treated early had a modified Rankin score of 0 to 2 at discharge in 48%, so nearly half of the patients were functionally independent at discharge, whereas in the late group that was only 28% of the patients. And what's also important is if you have a look at a modified Rankin score after 3 months, you see that the patients in the early EVT group continue to improve up to nearly 2/3 of the patients with a good clinical outcome, whereas the patients in the late EVT group basically stay the same. So, of course, we might need more data. This is a retrospective analysis, limited patient number, and so, of course, but maybe it should be more like a time-to-brain approach also for venous thrombectomy in these patients. So to summarize my presentation, as I said, early EVT with rheolysis seems to yield improved clinical and anatomical outcome, time-brain approach. The combination of rheolysis and mechanical clot fragmentation is, at least in our experience, a promising approach. However, I think we also agree that the tools for venous recanalizations are not yet good enough. Maybe this might change now with the super large bores, and also cyclic aspiration might be a huge improvement for this. Thank you for your attention.
Thank you very much. Very impressive presentation. Are there any comments or questions from the audience? It's very impressive. I can share we still were afraid or more conservative to do that. We stay at the group with full heparinization. Can I ask you something? You mentioned one failed EVT,
yeah,
and you go for aggressive also antiplatelet. It's a standard antiplatelet or something specific you add for the anticoagulation?
So in this case we went for aspirin and ticagrelor because she was pregnant.
Okay.
And the thing that really worked in the end was infusion of eptifibatide for 14 days, actually. 14 days, yeah.
And so for how long you're going to leave also the double antiplatelet therapy? What period is your suggestion?
Actually, you have to check the patient, how the recanalization was. We did follow-up MRIs and saw, okay, it starts to recanalize, and then we said, okay, we keep going for a few more days to be on the safe side. She started to wake up. She was comatose before. She started to move. She woke up. And then we said, okay, we do it clinically. Started with high dosages of ticagrelor according to multiplate and verify now testing. And we kept her on that throughout the whole pregnancy. and she and the baby were doing fine. So it was
So
more like
imaging
a...
modality, clinical evaluation, everything is good.
Yes.
Then you don't reduce immediately the antiplatelet,
No, no.
leave it for several days, then stick only with anticoagulation, right?
Yep.
Okay. Important to know.
Do you have any Behçet disease patient?
No. Mm-mm.
In Turkey, we have actually the Behçet presenting 10% of them has a sinus thrombosis. Because of the vasculitis situation, do you consider to do the same treatment with them? Normally, the clinician doesn't want us to touch the patient, even the angiography. They don't want to do.
I think I would try, yeah. Especially with the high clot burdens or the severe symptoms, yeah, I would not wait. I would try,
Yeah, we are arguing with that. Also, I'm in favor to take it, especially in acute stage, as much as possible.
Yeah.
Yeah. Thank you.
Thank you once again. So we continue with Professor Kocer from Turkey. He is going to speak about his experience with dural venous stenting in intracranial hypertension.
Thank you. I would like to thank you again. Nice invitation. This is my second time in your country and meeting. Let me talk about the dural stenting. Of course, we are doing a lot of things transvenously. I will not mention about those things to you. I mean, the AVM and dural AVF treatment. First thing first, everyone should aware that unilateral dural sinus stenosis is not rare. 1/3 of us, in a variation, we have this. That's why in this pathology or morphology, we need to really careful by selecting the patient. Stenting focusing on two subjects, that the idiopathic intracranial hypertension, you may say the pseudo tumor, and also pulsatil tinnitus in combination with or the separates. Mostly, this is a kind of a sign that patient having an intracranial hypertension if you have a pulsatil tinnitus. But there are certain cases they haven't got hypertension because of maybe they have a leak, subarachnoidal leak, spontaneously. Many the entity can cause pulsatil tinnitus because pulsatil tinnitus is alarming symptoms for those group. That the hypertension is a little bit difficult to diagnose, but tinnitus is something. They are coming to the physician, and you need to take care of all those entities before attempting the dural sinus. Just starting that two cases with different pathology than the hypertension, but these are the hypertensions also, but not pseudo. Look at the AVM case, and then look at the sinuses, maybe a tiny stenosis here. In three years, she became comatose because the left side occluded and right side had a critical stenosis. Eventually, there is a retrograde venous pressure elevation, and then classical parenchymal problems also affecting the clinical symptoms. And then the very early case that I treat with the balloon and the stent at those years is something 2000. And I'm not using balloon anymore, by the way. We didn't know that balloon is necessary or not. Still, there is a discussion about it. Another case, presented with enlarged veins. It is obvious that there is a high flow fistula here, and the right side is occluded again. High flow venopathia, you may say so. The other one is also almost occluded. But we need to treat the brain, not the fistula. That's why, look at that, the whole that kind of a Chiari type, the herniation, and then look at the vessels in the brain. And then the first thing first, I did a compliant balloon angioplasty just to get rid of the stenosis, not stenting at all in 1-year-old boy, and then treat the patient, and then get rid of the venous high pressure, and then solve the issue without stenting. The same thing happening in the hypertension cases. This case had a headache, blurred vision, typical hypertension. Look at the stenosis on the left. There is really tiny vessels on the right. And going up and choosing the longer stent, I will explain why. This is the 3rd month follow-up, eliminating all the symptoms immediately in the same week. But impact of the length of the stent is also the point of discussion. There are cases, up to now I haven't, but there are cases I will have. If you select short stent in hypertension, and if you don't eliminate the factors of the hypertension, you may have secondary stenosis over the stent. And then you need to do another stenting there. Look at that, from here to here. There is the selection mentality in this group. You need to create select the stent longer. Another one, all this MR findings is compatible with hypertension. Look at here, and also the optic nerves. And this is the stenosis, careful analysis of the vessel, and the minimum manipulation. That means the tiny guide wire and microcatheter, and put a good radial force stent, but enough radial force, and then get rid of it without having angioplasty. I don't care this. I don't force myself to eliminate this. And immediately after a week or 2 weeks, that all papilledema findings is gone. Headache is gone. Some of them still headache is continuing on. Because of that, we didn't understand the factors of the hemodynamic, the brain system, lymphatics totally. But majority has benefit from that. Please note that the supracellular system before stenting and after stenting. Very dramatic morphological change, and 3D, 3 months vaso CT IV, the imaging. And also, you can explain the turbulent flow mechanism of the tinnitus, especially the vascular tinnitus, the venous vascular tinnitus. There are arterial tinnitus. One is systolic, the other one is diastolic periods. But patient, if you ask, patient will describe to you. And what I'm doing, I'm checking as much as possible. And I'm asking the diagnostic group, do whatever you want for the hearing, because those guys become the deaf at the end. They're losing their hearing. And the IV, high quality MR venography in combined with this type of functional imaging is really nice, reducing the X-ray, having every data. And when I get it, I'm not doing lumbar puncture anymore. Last, most probably 15 years, I stopped it. I'm not doing, I don't need that one. I need the clinical findings, the ophthalmologic findings, and audiologic findings. MR show me everything. Even I stop measuring the pressure in the dural sinus, because whatever you do, it is fake. Whenever you turn your head, you are changing the pressure. It is well documented. Why should I bother myself, add additional manipulation to measure the pressure? Everything is in my hand. And then for this tight stenosis, after multiple projection, you need to elevate the AP angle to get this image, not a regular AP. And then problem is the size of the sinus. The problem is we haven't got good stents in our hand. And then after that, you are trying to do the stop here, because this stent is 8 millimeter stent. If you go there, there is an opposition problem. That's why I need to stop at the edge. And these self-expandable, retrievable stents give you a chance to do so. Again, no balloon. In my protocol, in 6 months, I'm doing contrast-enhanced MR venography and MR to check everything. That's why I need to see the in-stent, and that new generation of stent give you a chance to do so. With carotid stent, you have problem, especially in wall stent. I will show it to you. In 1 year, I'm doing regular angiography. In the angiography, you need to inject the different vessels, including the vertebral and internal carotid artery, to see the whole cortical veins. Don't stop with single injection. There are potential complications for sure, as you read. Let me show you some. This is the case. Again, the intracranial hypertension and tinnitus, and everything is done. You see the optic nerve sheath and large empty cella. And what I'm doing regularly, I'm putting a dot, new generation of the angio, you can do that, to show me the labbe's position here. Most of the time, labbe is in the stenotic segment, most of the time. And then you aware when you cross the labbe, and you need to check with angio, did you have a stagnation in the labbe or not? And that point, the stent radial force is important, because the dural sinus are not circular. That you don't think that they are vessels. They're not vessels, they're channels. Jugular vein is a vessel, but dural sinus are not. So after the 80% of deployment, you may check. If you don't happy with that, you may take the stent out and change the diameter if you have a stagnation. And this is after the stent. This is the intra-arterial imaging. And this is another case with the wall stent. And I stopped using wall stent because of certain reasons. First thing first, is rigid. Every carotid stent is rigid. And then you need to use the stiffer guide wire to carry it. You need to use a distal access catheter to carry it. Even though you carry it properly, it's a nice stent to deploy, I agree. But this is not what I wish to have. And then look at the labbe stagnation afterwards, after the carotid stenting. This is the images of the immediately after. And I wait for a while, and then repeat the angiography. This is immediately after. You see the stagnation. And this is half an hour later. Little less. Unfortunately, you are increasing your heparin, and then we haven't got complication from this case. And do I have more time?
Yes.
Okay, thank you. Just let me know. And the same case, when you come to the follow-up, of course I'm using MRI because no X-rays and giving more details. Look at this, you have no chance to see in-stent region, zero. This is the problem of wall stent, but I like to see it. I like to see what is going on there. So look at the artifact. And that's why I'm not using anymore than the wall stent, because the size of the wall stent already covered by the new generation. And even with the distal access catheter, as you see in this case, and this is also the carotid stent is precise. In this jugular bulb, time to time, you need to push the system. With this case, I had a complication of the nerve 11, accessory nerve, and the patient had a problem in the trapezius, ipsilateral side. Don't do bilateral stenting, especially with carotid stenting. This is a big fault. You may lose vagal nerve in both sides, and you can lose the case. that there are cases somebody is presenting in the meetings. Don't do it. And then this is all problems of the navigation, not the disease itself. A navigation problem. Even with the distal access catheter, I get this complication. Fortunately, this patient healed. And then in the follow-up, and there's no problem. Again, the same problem, discrepancy of that the vessel, I mean the channel. I need to stop here. I need to accept this opposition problem, but it is working. The patient is asymptomatic. And another case, the double stenosis, and this is, whenever I saw this, the Acanthes create that stent, and then I shift my mind. I think I'm one of the first one who used Acanthes stent in dural sinus stenting. And then there are 8 millimeter version or 10 millimeter version. By using 2, you can cover almost the all kind of stenosis in the region. And this is again microcatheter manipulation. With the 10, you need to use the 39 microcat. That is the differences than 27 for 8 millimeter one. And then another one, the only one I believe I did an balloon angioplasty after stenting because of this. I didn't like that one. Again, because of the discrepancy, I obliged to use the smaller diameter of stent. And then I had a kind of stenosis here. And I did a balloon angioplasty. This is the only one case I used balloon angioplasty after stenting last 15 years. And before that, I was using. And this is after balloon angioplasty. All of them healed. All of them has no tinnitus at all, 0. Clinically, I'm very happy about it. Another one, still, these type of things my problem in my mind. That there is a occlusion. This is collateral flow in the jugular vein here. Those are collateral flow. And then the patient has symptoms, and I'm using contralateral side to come in and the stenting. I have still some problems with stenting in jugular vein, and if you want, we can discuss. Another one, again, that the stenting, eliminating everything. Most of the patients are suicidal. They're not saying so. Most of them, especially long-lasting tinnitus, they are coming that age. And hearing loss. If it is more than a year, the hearing loss started. And I look at this after this disappearing. If you are quick enough in terms of the clinical sign, they are healing also. The leak that is in hypertension, now there are studies and the group are doing. Even that spontaneous, the cerebrospinal fluid leak, you can treat majority of them by using stenting if they have a stenosis. If you eliminate the subarachnoid space pressure, and you may make it done without having surgery. This is something new for our society, that we need to take care of this. With the leak, you need to do IV, contrast, enhanced MR venography to check is there any critical stenosis or not. Without doing so, don't send the patient to the surgery, because surgery results are not optimum. And that now the papers are coming, everyone doing stenting all around the world. We know that, that's good, and that's interesting. Another one, again, the hypertension, see that the variation on the left, and different projection, good measurements, and also using a longer stent because it is intracranial hypertension. And for this, forget about it. Don't use a balloon. Look at this part, okay? And the patient clinically turned back normal. This is 5 months. Look at this better, and this is year. Look at the differences without angioplasty. You need to know the mechanical properties of your stent. Very, very dramatic, spontaneous, no touch. Minimum manipulation, and done. So the reverse study is here, is promising, and we are having a stent specifically designed for the dural sinus. This is the guy in 2002, the first time used the venous stenting. I need to mention his name. And then also there are divertical. I have no case for that. You can call it, and for the tinnitus. In conclusion, that is what I'm saying, a summary of what I'm saying. Careful selection of the patient is the key of success. And technically, I mentioned already. And work with the clinician as a team is important. And thank you for your attention. I hope I can see you in Lisbon this April.
Like every time, thank you. It was really, really impressive for that new pathology we are dealing every now and then. Are any questions from the audience?
Yeah, I have still in learning curve for this venous stenting, even though I have a lot of case, but I'm still wondering what will happen. That's why I didn't change my aneurysm protocol. I'm applying the same to the venous. No, actually, I'm using, if it's not elderly, I'm using single antiaggregation last more than 15 years, parasugrel, if there is no resistance, single. But I'm using longer than the other teams. In 3 months or 6 months, I'm not cutting it. In at least a year, because theoretical knowledge of the healing of the vessels is something in between 6 and 9. I mean, maturation of the healing. That's why I'm not cutting it.
And for loading or preparing, 5 days?
Always loading. There is no emergency if there is no suicidal.
5 days?
The clopidogrel, you need 3 days. That's enough. Clopidogrel, yes, 5 days. Parasugrel, 2 days is good enough.
Thank you.
You're welcome.
Can I ask you, because we are arguing with our neurosurgical team all the time that they're afraid we are not going to deal with the symptoms, how many fails you have not dealing after dealing with the stenosis, not to regress?
Sorry saying zero, but zero. But because those cases, I'm really very vigilant and very careful to selecting the cases. I have 0 case to get rid of tinnitus first. But I have some cases, headache, still having some headache.
Persistent for some time?
Sometimes.
Okay.
And the majority of them is gone. Some of them, you cannot measure the headaches, the severity. It's all subjective things. But every patient has the benefit. I may answer like this.
So
but
you
tinnitus,
know a gradient,
zero.
No gradient in which you can say the patient, maybe you should experience no bettering of the symptoms? Because you said you doesn't measure the gradient?
I'm not.
So there is no number.
That is giving extra risk. In lumbar puncture, we are saying that it is okay, it's safe. It is not safe. You know, I'm not doing lumbar puncture. All my case, I have 0 case. I may say 0, because I'm intentionally not doing so.
I'm listening very carefully because I need to hear you, like experienced guys, so I can motivate myself tomorrow in front of them. That's why I'm asking so specifically for the selection of the patient.
You may show my picture to them.
Finally, do you have nowadays recommendation for the stent? Because you suggest us to use the Caresto, and it was very nice. You stick nowadays to the Caresto, right?
You mean Akandis?
Yes, the Caresto carotid stent.
Yeah. That is the stent now available in the market through the microcatheter, simple manipulation. But we need better. I'm searching for better, because I'm searching for the other stent is coming to the market. We will see.
Okay.
I'm not fixed myself in one company stent. So.
Yes, but nowadays we are starting with this pathology. It's very important to start whatever you learned from now, not to go back for the
you did the
stent.
case, you know, after consultation, it went well as far as I know.
It was perfect. That's why I'm asking. We are sticking to these kind of stents nowadays.
Putting the stent over there has not need the technical skill, actually. That's easy comparing. If you are doing aneurysm treatment, this is everyone can do it. The problem is how you are doing it. I mean,
Yeah, we saw the tips
even
and
within
tricks.
very experienced hands, I'm not modest about it, but I did that jugular vein compression complication. That is happening. It's all the selection type creating that complication. Don't manipulate too much. Don't use the balloon. You don't need to. And also use the microcatheter delivery systems, whatever it is, not the carotid stenting.
Thank you very much,
You're
Professor.
welcome.
It was very beneficial for us.
Youngest patient that you have treated? Depends on from years or something like that, because, for example, for a young patient,
Young mean below 10 or?
no, around 20.
Yeah, we have some of them, yes. Yeah, some of them. No change at all. Only the kid, the 1-year-old kid, that AVF group, I'm pretending not to put stent, and I'm trying to not to put stent if it is possible. And we don't know. We have no study for that. Only angioplasty versus stenting on those groups.
And if the symptoms are gone with, for example, conservative treatment like acetazolamide or something like that,
Majority of them already have acetazolamide for a long time. Some of them had a shunt. Some of them already have a optic nerve fenestration. And our surgeons and neurologists still insisting to follow the so-called conservative treatment. This is the biggest the resistance in my career. I didn't get that resistance in aneurysm. I didn't get that resistance on AVM. But this group, even that same neurologists have no resistance for stroke, thrombectomy, because they are doing it, okay? But in this group, in this pathology, still they have problem in their mind. But we are solving our mind properly by selecting the patient carefully and then communicating each other very closely. All around the world, we have friends working on it, promising. But I may say so, we don't know totally brain lymphatics drainage and also cerebrospinal fluid drainage. That's why I'm talking carefully. No.
Thank you once again. Wonderful presentation.